Hello.
Yeah.
Good evening, everyone. We welcome you all to Ortho TV, and we are live now. So over to Dr. John, sir. Take over the meeting.
Good evening, everybody. Welcome to this session of the postgraduate education talks. And today we have Dr. Gautam Prasad, our spine surgeon, who's going to talk to us about POTS. And I think this is again a long case that can come for you in the exam. Plus, you can have a lot of questions on management of tuberculosis and especially tuberculosis of the spine. So over to you, Gautam.
Yeah. Good evening, everyone. Yeah, so we'll be talking on a spine case, especially related to tuberculosis. So just last time we had a detailing lecture series for spine examination. So we'll be just going through the same thing. Few slides will be repetitive of that. Not most of it. So basically, when we come across a spine case in TB, basically the patient will present with one of these symptoms. It will be either pain, swelling, deformity, weakness, and in weakness it can be bowel bladder involvement, and activities of daily living can be hampered. So what one should actually check out for each and every symptoms, all the symptoms, we should go in details. One should inquire about how was the onset and how was the progress of the symptom and what has it lead to. So what disability it is causing in day-to-day living, that is more important, and that has to be noted down. Once we take the history, then comes the role for examination. In examination, one has to check out for the inspection, palpation, then do neurological examination. In inspection, check out what the posture of the patient is, check out for, look for heel toe walking, alignment of the spine, and is there any associated wasting of muscles? Is there any associated list? And is there any swelling in the paraspinal region, axilla or inguinal region? How is the curvature of the spine? Is it altered? Is it normal? Is there any visible deformity? If there is any deformity, then does it get corrected while the patient is standing or lying prone? So all this thing has to be noted during your inspection. And in palpation, one should elicit tenderness along the spinous process, look for any visible swelling. And if the swelling is there, what is the consistency? Is it soft? Is it firm? Is there any fluctuation positive? And the extent of the swelling. Deep tenderness, and also check out for any deformity. So if there's a deformity, does it get corrected when you actually make the patient prone and try to push it? Or does it increases when the patient is standing? So this gives us a fair idea how the deformity is behaving. And along with this, if the patient is having significant pain, maybe it might be because of an acute thing. And if it is a rigid heart deformity, it might be a healed infection which has led to this deformity. After this, one should check out for the neurological examination, the local examination, the basically motor. In motor sensory, in motor, we have to check out for the tone of the muscles and strength across all the joints. Sensory level, one has to compare the sensation with the forehead sensation and check out on either sides, compare with the either sides of sensation, and then do reflexes. In reflexes, one should elicit the deep as well as superficial reflexes and take care of not missing the abdominal and anal tone and anal reflex bulbocavernous, especially if we are dealing with a neurodeficit case. So this is a video which I had presented last time, and if you want, we can go through it or skip as sir says. Johnson? Do we have time to present this?
Yeah. Well, it's up to you. You have to finish within half an hour. So
Yeah. So we have time.
yeah.
So in this is how one has to make the patient first walk in a routine spine examination. Then check out whether the patient is able to walk on his toes, because if this is happening, then all the anti-gravity muscles of the legs, those are working fine, 4+ power. The plantar flexors and quadriceps are working fine. Then make the patient walk on heels. So if the heels are fine, that means the EHL, EDL, they all are 4+, the quadriceps are 4+. After the patient, then make the patient stand and check out for the range of motion. So if it's a painful spine, the movement will be restricted. So in those cases, try to be gentle with the patient. Allow him to do as much as possible side bending, bending forward, and make the patient sit and then check out for rotation. So if there is early infection, the rotatory movements are painful and the patient will resist rotational movement. If the patient is able to sit cross-leg, that means his SI joint and hips, those are normal. Then neck movement for if we are having a cervical spine case, flexion, extension, lateral flexion, and rotations. Then check out for the movements across all the major joints. Sensation part is being elicited. As per the dermatom, we have to check and compare it with respect to the forehead sensation. What I missed in this presentation was that the eyes should be closed. Then you check for grip. If the grips are fine, that means the introstia are working fine. C8, T1 are fine. The small muscles of the hand joints. Then check out for the movements across the wrist and elbow. Ask the patient to first get into a posture in which you want to elicit the movement. So if the patient, you want to check the biceps, let him contract the biceps and try to pull it. And similarly for triceps, ask the patient to make the hands straight. Similarly, this is for hip flexors. Then stabilizing the knee and checking for the quadriceps, hip adductors. This is to show how to check out for the tone. Checking for EHL on either sides, then the FHL. Again, eliciting the sensation on L5. This is S1 dermatome, and over the malleolus it will be L4 dermatome. Over the medial aspect of the knee, it will be specific dermatome for L3. Then one has to elicit reflexes, the knee, the ankle, and the plantar. In plantar, one has to be very careful. You just strike it along the lateral aspect, then go upwards and then medially. So if there is spanning of the toes with the extension, that means the plantar is positive. Also, the iliotibial band will contract at the same time. So the biceps, triceps is being elicited. Yeah. So once examination is done, then the next question will come as to what all things you would like to have your investigation. So the basic investigation in any case, we should start with X-ray. So what is to be commented on X-ray? So after you comment on all that, it's a plain radiograph, AP, lateral, all those views, check out how the disc space are. So as we go downwards, the disc space should go on increasing. The height of the disc that goes on increasing. So at this particular level, we can appreciate that the disc space has reduced. It has significantly reduced. Also, we can comment, it's not pertaining to this case, but if you check out the width of the foramen here and width of the foramen here, so in a typical LCS case with lateral stenosis, you get this stenosis of the lateral canal stenosis, we appreciate here, and the SCP, that is superior articular process, is further impinging into the nerve root at this level. In next X-ray, in the middle of in the center, it shows this is a pure AP view of the dorsal lumbar spine. So this is the this is better appreciated here. So this is the pedicle on either side. Here comes the lamina on either side, and this is the spinous process. So if we check out, this looks like an owl, and in this case, if there is a destruction along the pedicle base, then this is called as a winking owl sign, which is very classical of destruction. It might be seen in tuberculosis as well as in metastasis, not only in tuberculosis. And in this case here, yeah. So in this, there is a deformity. So most of times what we come across is the deformity is present, and there is an internal gibbous present over here, and there is too many vertebrae over here. So how to count the number of vertebrae? So always look at the pedicles and the posterior elements of the spinous process. In this, it's not very well seen, but in an MRI, one has to count the spinous process. So this pedicle is with this vertebra, here it's with this, and in between we can see 1, 2, probably 3 and 4. So this kyphosis over here, segmental kyphosis over here, is being formed by 4 vertebrae. After X-rays, the next choice of investigation is always MRI. So what all things are to be commented in an MRI? First of all, you have to first say as to what part of the MRI it is, and then whether it is T2 weighted or T1 weighted, in which the CSF will be bright, that is T2 weighted. So we can appreciate that the alignment is altered. There is a kyphosis over here. The bones are destroyed again. Thus, corresponding for this vertebra, the corresponding spinous process is this. So there is one spinous process, 2 and 3rd. This is over here. So in this kyphotic deformity, there is only one vertebra which is totally destroyed, and 2 vertebrae which are incompletely destroyed. And also we can appreciate that there is distraction of the interspinous ligaments. So that is appreciated at both the levels. And what we see over here is a collection. So there is epidural collection, and over here there is a prevertebral collection. So we can appreciate the prevertebral and epidural abscess, along with involvement of 3 vertebrae and distraction of the posterior element. In this film, we can see this is the T2 weighted, this is the T1 weighted. One vertebra is totally destroyed or partially destroyed. Sorry, it's partly destroyed with the abscess present in the prevertebral area, and some retropulsion seen here. Minimal abscess which has been appreciated here. This is a stir image. This is the contrast with enhancement, and this axial we can appreciate that there is paravertebral abscess along with some epidural abscess going along the nerve root. This is a CT. So CT is helpful in cases in which there is we want to delineate the bony landmarks and have better appreciation of the bone of bones. In contrast, MRI usually we do it and for diagnosis. In contrast, one can appreciate that there are local collections, so that helps at times to differentiate infective pathology and differentiate it from metastasis or tumor pathology. So after we have those investigation, many times we are asked other investigation, which includes the blood investigations, which like CBC and ESR, which are of utmost importance. ESR is mainly to prognosticate, because serial ESR can help to comment on whether the disease is responding to your medication or not. Next comes the paralysis. So there are various grades. We can either actually grade them 0 to 5, or we can use the Asia classification, whether it is complete, incomplete sensory, and incomplete motor, or combination of both, or it's totally normal. So depending on what the patient is able to do on ability to move or not, the various classifications are there. Also, once we localize as to where the sensory level is, the common question arises, or the examiner is very keen to know, how do we clinically note down as to where the spine is getting affected. So if we don't have an obvious deformity or the prominent spinous process present, then the sensory level comes to help. So always remember, the nerve root which comes out from C2 to C6, you have to add 1. So so if the C4-5 disc space is getting affected and there is spondylodiscitis, then you add 1. So C6 will be the sensory level where it will be from where downwards you will appreciate hyposthesia in that level. In the upper dorsal spine, between D1 to D6, you have to add 2. In the next lower third, that is D7 or T7 to T9, add 3. And we have all these corners present between D10 to T12. So at that level, all the lumbar segments will be originating, and below L1 and L2 level, all the sacral and coccygeal level will be seen. Below that, there is only quada equina. So once the quada equina levels are affected, that is L2 downwards, then depending on which root is getting involved, that particular lower motor neuron sign we can see in that patient. Another important thing is the management. So always in exam, whatever the case is, if there is no gross neurological deficit, which usually is not kept in an exam, so always try to first you would like to conserve the patient in the form of medications and rest, followed by mobilization with brace. If it fails, then I would like to check out for surgery, because the absolute indication for surgery are only going to fit into these 3 criteria. One is pain, the other is weakness, the third is deformity. Pain. So a unbearable pain, rest pain, which is not subsiding with adequate trial of medication, or the pain which is increasing while the patient is on treatment, that's the indication for surgery. Neurological weakness. So dense neurological weakness of the grade less than 3 power, or involvement of bowel bladder, these are absolute indication for neurodeficit which needs surgical intervention. A neurodeficit which appears while the patient is on treatment, or a neurodeficit which actually worsens, that is a reason for surgery, indication for surgery. Deformity. Now, deformity can be deformity which is being expected, that is instability, that will show up as an instability, or a deformity which is already there in a case of healed TB. So instability is something that the patient is not able to have a stable spine, like the patient is not able to sit, stand, change posture without pain. To begin with, each and every spine, as Dr. SYB says, every spine in which there is tuberculosis, it will be unstable because of the significant pain. There will be a significant spasm. So if we give adequate trial of bed rest and mobilization with brace, most of the times we get away, and these patients, they show improvement with conservative management. But those patients who continue to have significant pain while change of posture or while doing their routine activities, those are the case in which the instability is persisting, and they warrant a surgical intervention for stability. Deformity usually develops quite late in adult, and thoracic spine is more common to have a deformity because of the natural kyphosis it has, plus as the weight bearing axis passes anterior to it, the tendency to further increase in kyphosis because of the affection of the paradiscal area, that further increases. Also, as the further increase in kyphosis is there beyond 45-50 degrees, the muscles, they tend to just give way, further leading to increase in kyphotic deformity. So thoracic is more prone to have kyphotic deformity. In lumbar, it usually begins with a lordosis, the natural deformity, that natural curvature it has. So in lumbar spine, first the lordosis will, if it is getting affected, the bodies are getting affected, it will first get to loss of lumbar lordosis, and then the kyphotic deformity will develop. So there is usually long period to develop kyphosis in lumbar spine, but significant kyphotic deformity develops early in thoracolumbar junction as well as thoracic spine. So these are things that we have to keep in mind. In child, there is usually tendency to have early deformity because the child is in a growing age group. There is always a risk that Dr. Rajshekharan, which he has given spine at rest sign. So these cases in which there is significant destruction First, they're seen, what we see is usually the facetal distraction, then the retropulsion, and then lateral translation or toppling of the vertebra. So if these signs are being seen while the patient is on tuberculosis treatment, and the disease is active, the wet lesion, then these guys are, or kids are actually going to progress to full-blown kyphotic deformity, something like what the previous X-ray I had shown, in which 4 vertebrae were involved. So it's better to get a deformity correction in such cases when the lesion is wet, because that time the correction is easier. And when I say easier, manipulation is easier, and the chances of having a post or neurological weakness or deficit or handling of the cord, that minimizes if the lesion is wet. So all those things we have to keep in mind. And when we talk about deformity correction, there are various correction methods which one applies. In this, the basic thing is the Ponte's osteotomy, in which there is a facetal facet excision on the either side is being done, and gradual correction of around 7 to 10 degrees of kyphotic deformity correction is achieved at each level. Smith-Peterson, in Smith-Peterson, if the anterior disc, anterior column, that is a disc, is not calcified, it's mobile, then Smith-Peterson osteotomy can be done. In Smith-Peterson osteotomy, what we usually do is it's an extended or a extended Ponte's osteotomy, in which most of the posterior elements are removed till you achieve a union between the upper segment and the lower vertebra. Sorry. By this, we can achieve even up to 15 degrees of kyphotic deformity correction, kyphotic correction. Another is pedicle subtraction osteotomy. As the name suggests, you do the osteotomy keeping in mind with the pedicle. So along the pedicle, we go out along up to the anterior part of the body, and then it can be done either with the help of osteotome or decancellation process. So, and can achieve a correction of even up to 25 to 40 degrees at each segment, each vertebral segment. So depending on how significant the deformity is to begin with, one can choose the type of procedure. And in significant, in most severe cases, one has to do a total vertebral excision, which is called as PVCR, or posterior vertebral column resection osteotomy. Other reasons for indications for surgery are significant neurological deficit and significant neurological deficit and instability. So in these cases, one has to do decompression as well as fixation. Only decompression in which we do posterior laminotomy or facetotomy without instrumentation, that is actually going to be disaster. So always one has to do a decompression along with fixation, because one has to stabilize the spine at the same time. In only case where there is no need for fixation in a tubercular spine case where we need surgery is evidence of only posterior epidural abscess with no bony destruction. So these are not very common, but it is not very rare also. So in selective cases, one can attempt only decompression, but in most of the cases in spine TB, one has to do decompression along with fixation. Now, question arises about drainage of psoas abscess. Any abscess, whether it is psoas or it is prevertebral abscess in cervical or any other place. Abscess, as long as it's not causing significant tamponade effect, causing to significant pain or significant compression on some adjacent neurovascular bundle or causing significant discomfort, can be managed without surgical intervention. And for most of time, even up to one liter of abscess I have seen, or I have actually managed without surgical intervention. Next comes drugs. So drugs, usually we before I go to the drugs, what I missed in this presentation, I'm very sorry for that. In management, whenever we start the management of tuberculosis spine, one has to attempt a biopsy, obtain a culture, and then start with medication. This is a must because this confirms the diagnosis. To rule out other causes like metastasis or plasmacytoma or even brucellosis, fungal infection. It is very important to or even pyogenic infection at times that fools us. So one is for confirmation of diagnosis. Second, to obtain material for culture to rule out MDR TB. So this is going to be a big problem for us if the patient has got MDR bug. So always remember to first do the biopsy before we start for any medication. So medication, the first line, there are 4 HRZD, and always try to give your drugs as according to the body weight of the patient. So the new how one has to remember the HRZD, it is 510. HR is H is INH, isoniazid, R is rifampicin, Z is parazinamide, E is ethambutol. HRZ is 5, 10, 25, 15. So 5 milligram per kg body weight for isoniazid, 10 milligram per kg body weight for rifampicin, 25 milligram per kg body weight for parazinamide, and 15 milligram per kg for ethambutol and streptomycin. So when patient is on ATT drug, always you have to counsel the patient that the urine color will get altered to reddish color. Also, we have to check out for the LFT levels at frequent intervals. In the beginning, it can be done at every 2 weeks interval, and once the patient stabilizes, can be done at 1 month or even 2 months interval. That has to be done, and one has to always give Benadon, pyridoxine along with it, so as to nullify the effect of isoniazid. When it comes to second line are usually given for cases in which they are proven resistant. So in today's era, it's very important that not to attempt adding any second line to this. And the recent guidelines for from WHO and India's tuberculosis management committee, the guidelines have totally changed, and one needs to be aware of these 3 groups which are recently, since last 1 year, we are practicing this. So it's being divided into 3 groups. Group A, in which it is LLB, if you are very fond of mnemonics, Levoflox, linezolid, and bedaquiline. Group B is clofazimine, cycloserine, and group C is all the others that anti-tubercular medications that we know about, like ethambutol, delamide, parazinamide, imipenem, meropenem, amikacin, ethanoamide, PAS, all those things. So always remember this. And as of now, even a chest physician in a private setup is not being allowed to practice second line medication for drug resistant TB. One has to refer that patient for with a chest physician, to follow with the chest physician at government designated centers, because bedaquiline is being not being allowed to be open for practice with private practitioners. One has to remove all these things, and before you go for exam, just go through all these guidelines, because those are going to be important in your viva. And there are various regimes. There are 2 regimes, basically short-term regimes and long-term regimes. Mostly what is being preferred is a long-term regime. Till these guidelines are out, we used to give for at least 2 years, but now there are 2 terms, like the short-term and the long-term. Long-term is always preferred. It is between 18 to 20 months. It involves bedaquiline for a longer time. It's all oral medication which is being given in this long term. Whereas for the shorter MDR TB regime, it includes the injectables, and hence the duration can be shortened. But there are various pros and cons, and one has to be very selective. Like any of these drugs which are being used for short term, the patient should not have been exposed to any of these, and should not have been resistant to any of these or any other drug related to this group in past. So one has to be very specific, and if one is attempting shorter course for MDR TB regime. And of course, there are various pros and cons for these new drugs, and one has to be very much aware of this. Like in pregnancy and lactating mothers, bedaquiline is strictly contraindicated, whereas what we had the feeling like all the first line we have been studying is the first line ATT are all safe in tuberculosis except streptomycin. So that's it, and I think can have more time for discussion.
Yes, sir.
Great. Questions?
DNBs?
I think we had something on the drug therapy just a couple of weeks ago from Avinash as well, isn't it?
Yes, sir.
I think there should be some queries on that.
Yeah. On that day? Yeah.
So while you were talking about MDR, you now have two other categories as well, the XDR,
and the TDR.
TDR, okay, which is
TDR, total drug resistance
and total drug resistance. So you're now finding mycobacteria which are resistant to all the antibiotics. Those are going to be real challenges for the future.
Yeah, real challenges, and we are not authorized to even practice the second line drugs. So this is something that all the orthopedicians and most of the physicians should do that, because what's happening even at our center, there is a combination of so many drugs that all those treatment get messed up. Yeah, getting messed up. So even they are developing resistance to the second line.
Sir, good evening, sir. Sir, is there any provision of giving bedaquiline or delaminid drug after registration on Nixa app from private practitioners? I have heard that.
So what I was told by the chest physician at our center, even they are not giving those bedaquiline. So even the government has kept it strictly for the government chest physicians only.
So, sir,
to prevent misuse, basically.
So, do all patients need to be registered on the Nixa app
yes.
from government?
In fact, in private practice, one should all notify TB patients. So I have a register with me at my clinic, and even in Paris, if I get those, I give them the number of those agents with whom one is to get registered. Unfortunately, Paris has not kept that. Though I have made it that those people come and meet Dr. Talat and Asif, but nothing has happened in last 6 months. Means 6 to 8 months, whatever they are trying.
Okay, so I think we need to look into that and see what's happening. Okay, because I think we are not registering. We have other, not spine, but we are treating other skeletal tuberculosis patients. And
so just not related to our case discussion, but there has been a case in Gujarat in which the doctor was actually arrested for not maintaining the registration.
So I think since this is live on other platforms, maybe we should be a little careful of discussing other things. Yes. So we should work on how we can streamline it in the
sort of, Amit has one question. Amit?
Yeah, good evening, sir. Sir, what problem I actually do face is localizing these lesions. Okay, so in Asia scale, they have given certain nerve root for certain motor movements, like C5 they have given for elbow flexion, C6 wrist extension, C7 elbow extension, C8 long finger flexors, and C1 finger abduction. And then we also have the dermatomal distribution. So do the localization of lesions count to these motor or they count to the specific dermatomal level? Like, for example, if we have a sensory deficit in the C6 and C7 dermatomal levels, then how are we going to localize the lesion in case of a cervical spine lesion?
So you have to take into consideration both the things. So if C6 is the uppermost nerve which is getting affected, its C6 comes out at it's going to exit the vertebral column above the pedicle of C6, right? So the level of affection has to be C5, C6.
If we have, suppose we have sensory affection in C6 and C7 dermatomal level, so it will be one above. The spinal segment will be affected. That will be affected will be C5 and C6, right, sir?
So if that common dictum that yeah. So in cervical you add 1. In upper thoracic you add 2. In the lower add 3.
Right, sir.
Gautam has one question, sir. He want to know about category distribution.
What category?
Yeah, Gautam. Sir, it is Cat 1 and Cat 2. What is there in Cat 1 and Cat 2? Gautam, you can ask.
Good evening, sir. Sir, I have read in recent PSM book, sir. There is a newer distribution of categories, just like sir, category 1, 4, and 5. 2 and 3 are removed.
Yeah. 4 and 5.
It is for pulmonary TB, sir.
No. It is actually category 1 and 2 is given. For category 1, all are primary tuberculosis, and other than that, everything is in other than primary is in category 2. What I know.
No,
Now
sir.
that's changed.
Recently, category 2 also has been removed, sir. All cases is category 1, either new or old. Category 4 is sir, MDR, and 5 is XDR.
So Gautam, I'm not aware of this category distribution, so I won't be able to comment on that.
So one other
Okay,
thing,
sir.
Gautam, was this question of doing a biopsy in every case and only starting treatment after that. Now, I think this is ideal, but is it practical in all the situations? And I think the general consensus amongst most practitioners are if you have all the typical signs in an endemic area, you are probably justified to start ATT based on, but making sure everything else fits in, but watching them very carefully, because I think practically still in India, trying to biopsy every patient with spine TB is not going to be so simple. So what is your take on that?
So most of times I do advise for biopsy. In cervical, it is very difficult because in cervical one has to go anterior, and there I am actually not myself confident, and I can't trust on the radiologist. Other than that, I attempt to get an biopsy in most of the cases. If the patient refuses, I write down on paper the patient has refused.
Fair enough, but then that is not, if you say that I don't do it because it's dangerous, then depending on who's doing it, spine, even a thoracic spine biopsy can be dangerous. Okay.
No, in anterior approach, I find it very difficult because
Yeah,
one has to open it, but putting a needle, like approach will be open. So mini open one can do, but putting a needle, it's very difficult.
So what is the actual consensus on it in endemic regions? That's what I want to know. Because these people would have to write it in, or they'll get asked that in the exams. And I think most people still start empirical therapy when everything fits in. Okay, so you have the classical signs, symptoms, you have the paradiscal disease, you have all the sort of inflammatory markers.
Yes, sir.
Classic. So in that, so till recently, it was fairly accepted that if you have all these, you can start ATT. If it is a Western country, definitely not. But within India, is that still accepted or not accepted?
So I haven't read the 2020 guidelines in full details. It's like 120 pages of WHO, 120 plus pages. But before that, 2018 guidelines update on TB by WHO that mentioned in an endemic area with radiological evidence and clinical evidence, one can actually start ATT.
Yeah.
Even in the registry of TB that the government of India has given us, it has mentioned that based on clinical and radiological evidence, one is starting TB. So I think we can write that in an endemic area, it is permitted to start empirical ATT, but it's always preferred to do a biopsy.
Yeah,
that
and
these
then
students can
when you do your biopsy, you do suppose you don't get a positive result, but everything else fits in. What do you do?
So yes, that then two things which can be done. One is repeat the biopsy. The other is then start the empirical treatment.
So no, these are.
It has happened both ways. This is because the yield in even in Hinduja when I was there, yield was around 80 to 90%. It was never 100%. It can't
And
be
that
100%.
is in the best institution
Best.
possibly for this kind of thing in the country. Okay.
Yeah, that's
when
right.
you're doing it in different situations, your yields are going to be much lower. Okay, so then again you're back to
Empirical, but at least I have attempted. So, and then even if we don't prove it's TB, we rule out by the biopsy. We rule it's METs or not. That is being ruled out. So
But
the
I
categorically
think,
right, no, not metastatic, no
yeah, but
cancers.
I think whenever you do that, you need to follow the patient up very closely. And if within 2 or 3 weeks, or say 3 to 4 weeks, you're not getting some signs of resolution, then I think then a biopsy becomes absolutely mandatory. The problem is when people continue for a long time and don't then check, just assume things are getting better while the ESR keeps up and the lesion is still there. And that's when the problems come, because even if it's something more sinister, if you catch it within 2 or 3 weeks, you're probably within time. But if it takes longer than that, it could have spread somewhere and you're going to get trouble. So I think you have to be really careful when you start ATT based on these guidelines. But I think we are in a situation where sometimes we end up doing that. Okay. And that's true of other skeletal tuberculosis also. I remember 15, 20 years ago, if we found clinical and radiological evidence of tuberculosis of the knee or ankle, we would start ATT and give them maybe a slab or cast or something to rest. But today, for those areas, we would always biopsy them. Spine, because the biopsy can be a little tricky and is not without risk, that I think they still suggest that you may start empirical therapy. But if you do, you have to be really cautious about it. Yes. And you must have all the radiological and clinical things matching without any doubts to start it. And again, within a few weeks, you need to check that the response is adequate. Because the other reason, not just biopsy, the other thing is the culture. Yeah. It's important now to get tissue to be able to culture the organism because of the incidence of the resistance that we are finding now. So,
I have one more question.
Yeah, please.
What is the management of heel disease with paraplegia? Heel TB case with paraplegia.
Yeah.
So a heel TB with paraplegia means there is some element which is still persisting. Either it is a internal gibbous and deformity, or there is some sequestra which is still persisting, or in a rare case, there is ischemic damage to the cord, which is very rare. And in entire span of since I have joined orthopedics, I've just seen 2 cases of ischemic damage. So these are the 3 ways how we can have. So instability, deformity, internal gibbous, and ischemic damage. So accordingly, we have to investigate, do the X-ray and MR in SOS, at times CT scan, and then take a call. So if your MRI and CT does not show significant canal occlusion and there is no significant cord compression, it is ischemic damage, whatever do is not going to heal, so better not touch it. If there is internal gibbous, in this case, you need that internal gibbectomy. So depending on the deformity, the severity of deformity, then one has to check out the type of correction that will be done. So most of times now we are doing everything from behind, but anterior, posterior, only anterior can be done, but it's slightly more risky and more morbid as compared to posterior surgery.
Yeah, so today the transpedicular approach with getting around the cord in the front. Okay, so that's the practice, and you can do your correction of deformity and excision of whatever tissue you want from the body also through that approach.
Okay.
So I think usually it's a progressive problem which you find with a patient who's already got a kyphotic deformity. And then there's always this late onset and early onset paraplegia that you need to think of. And the late onset ones are the ones which are gradually appearing because of continual stretching of the cord with the progressive kyphus deformity. So you would usually need to intervene in those because they will not respond to conservative treatment.
So, one question from Amit that he want to know about girdle-like sensation, like something constricting like a belt, and what is its significance?
So typically in thoracic spine, all this pain in thoracic spine, it's included in red flag. So why it is so? Because those area most of the times it's either TB or some cancer which affects this, and the roots on either side of that affected area that it carries that sensation, pain kind of thing, which cause like a constriction kind of thing around the chest. So this is typically a red flag sign that one must be aware of. And even in a few cases, I have caught early tuberculosis with just tuberculosis, even in, cancer in one of the doctor's wife, as early as 2 weeks since the onset of disease. So this is one red flag sign where one has to do minimum an MRI, not an X-ray, MRI. See the MRI.
Sir, a few practical problem what during the clinical case examination, sir, that like in which position we should examine the patient in TB case, especially if like thoracic spine is affected or patient is having paraplegia, that some patient allowed to do log rolling, but not making the patient to sit down, and few of them are allowing that. So what to do during the examination, sir?
So the patient has got significant weakness. I think we should just examine in supine position, log rolling, all those things. Never attempt doing a sitting posture in those cases. You might actually worsen that, and that will be strict red sign in your result.
Yeah, so it also depends if the patient comes in walking, that's a different situation.
If he has a paralysis, it's a different thing. But if it's a paraplegia and you make him stand,
yeah, and if they come on a stretcher or a trolley, then obviously it's a different situation. So you need to, and again, acuteness of symptoms, how much pain they have. So you would have to base your decision on that.
so before the examiner comes to you, have adequate time. So in such cases, do the opposite thing. First, to do the neurological examination, do log rolling, check out if there's tenderness, ask the patient whether he's comfortable. If the patient is comfortable, not very cranky, then you make the patient stand, and then you. Otherwise, the patient is slightly in pain or moderate in pain, but you actually irritate him right in front of the examiner. He will make some sort of thing. And that has actually happened to one of our colleagues. So one has to be very careful as to you don't irritate the patient, because many times it's the same patient who is being rotated.
Yeah, and you can ask the patient, is he able to sit or is he able to stand, etc. Okay, and if he says no, I can't sit, then don't try to make him sit or stand.
Don't do that. Yeah.
And about the exposure, sir?
Sir, I have one question.
Yeah,
sure.
Exposure.
Do we always stand to the right side of the patient, or we can stand left side while checking on the left limb? Or
so if you're a right-handed person, you have to be on the right side, because that's where the natural thing will happen. Natural practice of the arm. It's not depending on the. So if you're bidextrous, you can stand on either side. But if you're right-handed, right dominant, then you have to.
Where's the noise coming from?
So my child is actually just.
Okay, so one of the things, so by convention, you stand on the right of the patient. Okay, now if you find there's a problem in the left side, no one stops you from then going on to the left side to examine it in more detail if you think you need to. But by convention, you start your examination on the right side of the patient. It's not a hard and fast rule, but that's the general convention that's followed. Okay? Now, if you find you need to examine the left side, then you need to go to the left side to examine it. Okay? So,
yeah. Sir, one question about
while doing sensory examination, sometimes there is hyperesthesia instead of hypoesthesia. Does that make any difference?
Sir, you are muted, sir.
So what does hyperesthesia mean?
Sir, while touching the patient is saying, I feel more sensation over there.
So what does that tell you?
Opposite is hyposthesia.
No, it's opposite of hyposthesia, but what does it signify? That means there's irritation of the root rather than compression, okay?
Yes.
So could be the early stages where even in a disc or something like that, you will initially get irritation of the nerve root rather than compression of it, yeah?
Yes.
And, sir, that one question about the exposure, sir. For a spine case, it is for a male patient, it should be exposed completely, sir. That is okay, no, sir? Or
No, you never take, you always make sure they have at least
something
underclothes on. No?
undergone.
If you have to examine the genitalia, that's a different situation. You do it, but don't make him completely naked. That's not fair on patients.
And about the one question for the last discussion, sir, that about the KFT and LFT till when it is abnormal, when we have to change the drugs or to reduce the dose.
So generally, if it is raised up to 3 times of the expected normal, the higher level, without any symptoms, there is no need to change it up to 3 times.
That is for alkaline phosphatase, not for everything.
Even SGOT, SGPT, sir.
Yeah, that's what I'm saying. For those,
SGOT,
not for creatinine and things like that. Huh?
Not for creatine. For creatine and bilirubin. Bilirubin, if it is raised, and creatine, if it's raised, then you have to alter the dose. You have to actually stop them. And
so the enzymes you can allow up to 2 or 3 times, somewhere between that.
3 times.
Without worrying about it.
Avinas? Yes. You have any question? Okay. Sir, about that one test, MAN2 test, any significance for current scenario?
Don't do it.
Okay. And
no value in terms, the only area where it may have some value is, especially in India, it has really no value. Because
what test, sir? I didn't get it.
MAN2 test.
MAN2 test. Okay.
So some people say that in miliary TB you can do it too, but I think in India where a lot of people have had BCG and things like that, I think it's really no real advantage.
So MAN2 test, even that TB gold test, those are of
TB gold is again something
no
which
use.
They are. I thought it was banned, but apparently not, because recently I heard of someone who was put on ATT based on TB gold again. So I think
still we are getting some prescriptions.
It is categorically recommended by the government not to do it, but not banned because worldwide it's being done.
Yeah, the other thing is, this came through a sort of phase where initially it was PCR, okay? PCR from the blood, which had no value at all. PCR from tissue may have some value, okay? Then it became TB gold and various other things, which are, and I think all of these are really, eventually you need to either get biopsy or culture, okay?
Sir, can we say that the negative Montex test rule out tuberculosis?
Not at all, okay? Because patient with miliary tuberculosis will not have a positive Montex.
Even if the patient has TB, it can be negative. Why?
Yeah, because the resistance.
Immunodeficiency.
Yes. So if the CD4 count is below 400 or so, you can have that.
And sir,
it's pointless actually. I think some people do it for some. I don't know what they do. There was some indication for doing it, which is to talk about sort of.
So in immunocompromise, it being negative, and then after treatment, while on treatment, getting positive is actually being held as a positive response.
So when they give this immunotherapy, etc.
So
then it's being termed as a positive, better response.
Yeah, I don't think it has any value in regular.
But not basically.
And sir, for practical purposes, sir, for all the tuberculosis patient, we should do viral markers. So we can, or is it?
Why would you
for HIV and also?
Why?
So
because association is quite common. So do we need to do viral marker?
Why? Explain to me why. No?
Sir, because
sir, they say every tuberculosis patient should screen for HIV and every HIV patient should screen for tuberculosis.
And
Who
that's
says
made
this?
mandatory, sir. That's being made
Really?
mandatory by the government of India. That registry, which I'm filling, I am expected to write about sugar levels as well as the viral markers. In fact, government of India is doing that free of cost for these people. For all those people who get enrolled through that register, all these tests are being done free of cost, and they are being given medications and some 500 rupees per month
So
by
the
which you are.
patient, I don't know, can't patients refuse it?
Patient.
Yes, sir. Of
Actually,
course.
Indians don't do that. Anything in free is actually.
Yeah, because I mean, in practical terms, so like we've had a couple of 3 or 4 year old children with skeletal tuberculosis, and I mean, if you're operating on them, then automatically you do viral markers. But if it's just for treatment, I don't think I would do it on a regular. But if it's become mandatory, then you have no choice, I guess. So then there's no question. You have to do it. So
You have to do it, yeah. In exam at least you have to say yes.
I'm not sure about mandatory, sir. So come.
No, but are you sure this is mandatory?
So in that register, I'm supposed to fill that. I'm actually filling that.
No, but I have not heard of any such law that every TB patient has to have viral markers, or any such.
It was recommended. That's what I have read somewhere, but
okay. No, but it'll be interesting to know, because if it was, then if it is a so who has made it mandatory? The government.
So it was made because the quantum of HIV, the rise of HIV and tuberculosis in association with that was significant. So that it was made quite long back that every TB patient you have to screen for HIV. Not all the viral markers, only HIV.
Should check on that, because
but in practice, we are not doing unless those registered patients. Okay,
so, but by law, you have to register every patient now.
By law, we are supposed to. Yeah. Paras mein that's an issue.
Just one last question, sir. For few of the MRI consist of myelogram also. For any specific indication, we should write the myelogram too, sir. Or
myelogram is actually of no significance. That MR myelogram is actually taken out, reformatted format of the axial and sagittal. It's being taken. Usually, it's of no significance. The plain MRI with contrast. Any case we are suspecting with contrast. And also one point to be noted, while commenting on healing, there is no role for contrast, because in contrast the inflammatory inflammation can persist even after the TB has healed. So there are studies in which the TB has healed, but still the patient on MRI contrast shows active lesion. So contrast is helpful for initial diagnosis, but not for commenting on the healing status.
Okay.
As it is the radiological lag is there between the clinical healing and radiological healing.
I think it's 8:30, so 7:30. So we should.
Yeah, thank you so much, sir.
Most
of the things we have. Yeah, we have covered.
Gautam, and
yes, sir.
Over. Okay. Till next week.
Yeah. Thank you so much, sir.
Thank you, sir.
Good night.
Bye.